Rachel Bluebond-Langner. Welcome to OA.
Thank you for having me.
No, I'm so happy to have you here. So I wanted to see you here today because of the fact that you are a doctor who specialises in gender affirming surgery, and it's something that not only am I very curious about, but I know that there are a lot of kids and parents out there who would like to and who need to know more about the process of transitioning, and you are an expert. And so I just want to ask you some questions if you don't mind.
That would be wonderful. Thank you for having me.
No, thank you. So first of all, what led you to wanting to specialise in gender affirming surgery?
So I'm trained as a plastic surgeon, and for me, gender affirming surgery is sort of the embodiment of plastic surgery. It's the restoration of form and function, and you use multiple techniques, microsurgical techniques, craniofacial techniques, general reconstructive principles to restore both form and function. And there's a creative and artistic component to gender affirming surgery that I was particularly drawn to. But most importantly, for me, this patient population was incredibly grateful. It was a real opportunity to have a meaningful impact on somebody's quality of life. And I feel really privileged and humbled, quite honestly, to be a part of each patient's journey and transition.
Yeah, it sounds incredibly rewarding. I guess let's just start with what the steps are. So let's say there's a parent who's watching this and they're like, my child has gender dysphoria or is certain that they would like to transition. Mm-hmm. What is the first step that they take?
I think it's important to remember that transition is different for every individual. So I think that oftentimes we think, first you transition, then you go on hormones, then you have surgery, then life is perfect and everything is changed. But that's not true for everyone. So some people will socially transition, meaning they will change their name, they will use different pronouns, they may dress differently, present differently. Others will go on to have hormones, but again, hormones aren't necessarily for everyone.
Mm-hmm.
And
what do hormones do?
So hormones will change sort of what we consider secondary sex characteristics. So if you are assigned female at birth, but identify somewhere on the transmasculine spectrum, and you begin testosterone, you will see the development of masculine features. So you may see hair growth, the development of muscle mass, hair loss even, so male pattern baldness.
Does your jawline change at all?
So that's interesting. Generally, your jawline doesn't change, but if you begin puberty blockers, so if you halt the process of puberty around somewhere between 10 and 12, and you just put a pause button, and you don't allow the body to be exposed to testosterone or estrogen, and then you introduce estrogen
a
or
dominant hormone,
testosterone, you will see that you will potentially prevent the development of male secondary sex characteristics. So the face may be more feminine. If you, let's say you're assigned male at birth, you identify as female, you are placed on puberty blockers before puberty has started, and then you're given estrogen, the masculine features of your face, you potentially avoid that, and you potentially prevent the need for surgery. And the opposite's true for, let's say you are assigned female at birth and you identify as male and you begin puberty blockers before puberty has begun. You may not need chest surgery to remove the breast tissue, or you may be able to have a more limited incision for the chest surgery.
Is it traditional for people to know so young that they should be on a hormone blocker?
Probably not. I think that increasingly people are aware of puberty blockers and access to puberty blockers, but puberty blockers aren't necessarily available. It may be difficult to find a person who is able to prescribe puberty blockers. It may be difficult to get coverage through your insurance. Parents have to be supportive. There has to be the appropriate mental health team and multidisciplinary team to support the child.
Tell me more about that.
when somebody transitions and seeks medical intervention, hormones or surgery, they're cared for by a multidisciplinary team. So this is true particularly for surgery. Somebody doesn't just show up and say, I'm here,
want to transition,
I've transitioned and I want surgery. There's something called the WPATH Standards of Care. So the World Professional Association of Transgender Health has set forth guidelines. And it's recommended that the individual be cared for by a mental health provider that is knowledgeable in the diagnosis and treatment of gender dysphoria.
And will you break down what the actual meaning of gender dysphoria is?
The gender, you do not identify with the gender that you were assigned at birth.
Okay, great.
And people will potentially seek medical intervention, but may not seek medical intervention. And medical intervention comes in a variety of forms: hormones, surgery,
etc.
supportive care.
Yeah.
Yeah.
Okay, so when you have this group of healthcare providers, the mental health evaluations, what are those like? I mean,
So I think historically they can be felt by the individual as a gatekeeping measure. Why should I go to see a mental health provider for surgery? This isn't done for any other surgical procedure. And I think it's unfortunate because people will see a mental health provider that may not have an extensive experience with gender dysphoria and gender affirming care. So we hope that the purpose of the mental health evaluation is not to in any way deny your identity, prevent you from transitioning, but more to work through the excitement, the potential challenges. When is the right time to start hormones? When is the right time for surgery? Is surgery right for you? Is now the time? So,
and what to expect later.
Right, and how to prepare for it. How to get it can be hard for your partner. It can be hard for your parents. How to get your family on board to better support you. So it should be how to help you get to your end point and your goal, not coming in, I've diagnosed you.
I'm going to test you to see if you really need this transition. Yeah,
it's not a test. It should be, I'm here to support you and help you. I know that this can be hard to navigate, but I'm here to help you navigate it.
Great. Well, I hope people find those healthcare providers, but I know often they don't, unfortunately, in certain places in the world.
Yeah.
Is there a certain amount of time someone has to have identified differently to how they were assigned at birth before they are considered viable for transition?
No, I think transition certainly socially, so changing names and changing pronouns is when that individual is ready and feels able to. For certain surgeries, there are recommended time periods on hormone, time living in the identified gender. For example, for genital surgery, it's recommended that the individual have been on hormones for a year and have been living in their identified gender for at least a year. For each individual, the time to surgery may be, a few years after transition, but it may be 40 years after transition. Because, as I said, the timing of surgery or the timing of medical intervention can be complicated. You may need to navigate your job, family, relationships.
I just wonder because I know that I've heard a lot of parents of their children who want to transition are just like, well, this has all happened very suddenly. A month ago they've told us they want to transition and now they want to actually have a surgery for that. This feels too soon. It feels like this is a rash decision. Or, you hear the very rare stories, vastly circulated, about someone who's transitioned and then wants to transition back. And those rare cases are constantly spoken about as if that's the norm of the situation.
Right.
Would you, as an experienced surgeon, say that that's your experience, or mostly
it is not my experience? And we don't move more slowly, but we move slowly and cautiously in people who are under 18. And it's a multidisciplinary approach, so the pediatrician, the hormone provider, the mental health provider, and the family are all involved in the decision making. And again, it's not that the surgery may definitely be right for the individual, but when is the right time? So right now may not be the right time. It may be that it needs to be coordinated with schooling, with other stressors.
If someone struggles with anxiety or depression or mental health conditions, that maybe are slightly more affecting of their everyday life, like bipolar, for example, would that person...
So those issues need to be addressed first and together. Certainly gender dysphoria and living in a body where your anatomy is not congruent with who you are can produce anxiety and depression. But there are additional stressors that can result in anxiety and depression. And it's important to remember that surgery treats gender dysphoria, but doesn't necessarily treat all causes of anxiety and depression. So we have to make sure that we're looking at everything and that we're treating or optimizing the treatment of the depression and the anxiety so that the individual can really benefit from the amazing experience of having surgery. So in our experience, in the properly prepared patient, this is a life-changing and for many life-saving operation.
I personally really struggle when people try to link mental health issues with trans people. And they try to say that the suicide rates or mental health statistics are somehow tied to someone being trans and never think to examine how our society treats trans people, and could it possibly be that perhaps the depression, the anxiety, or the suicidal thoughts are down to the fact that we, in the vast majority, make trans people feel so unwelcome and otherized. And it's wonderful to sit down with a doctor rather than someone who's just a supporting opinion over fact about something that makes far more sense. As if someone is, like, as someone who myself is a minority and has struggled with depression and anxiety because of how I've been treated for being a minority, I can say that it's not as much of a catch-22 as people treat it as.
No, marginalization, discrimination, which trans people experience every day.
From so many people inside and outside of their family.
Results in depression, anxiety. Because of discrimination and marginalization, unfortunately, trans individuals are fired from jobs, not promoted in jobs, lose family, lose friends when they transition. And so that in and of itself is a huge stressor and can exacerbate anyone's mental health.
And so can not having the transition and having to live
Exactly.
in a way that you feel is a lie and not true to yourself.
Right. And so they give up. I think when somebody transitions, potentially they give up or they are at risk to lose a lot. But it's something that they need to do to be able to live life.
And you've seen it be really worthwhile and beautiful and moving to,
Yes.
I imagine, most of the people that you've
Yes.
taken through that process.
I think
I've actually met someone who you've taken through that process before, and he is incredibly happy to the point where he doesn't even want to lose the scars from the surgery.
Well, that's amazing.
That's how much he loves the surgery. That's how much it meant to him, that he considers it beautiful and says that it means the world to him. So I think that's really cool.
I think for me, that is the reason I really feel privileged to do what I do and love doing what I do. We're able to be a part of something that's incredibly special in somebody's life.
So I didn't know this. I always presumed you had to take hormones alongside a transitional surgery. That is not the case?
So,
and pardon me for my ignorance. I'm still just learning.
So there are many different gender affirming surgeries. And for genital surgery, it's still recommended that you take hormones for at least 1 year.
Can I ask how that impacts your mood and your just general feeling of...
So I think that hormones can affect people in vastly different ways, just like hormones in cisgender people.
Yeah, I feel affected by mine today.
Yeah.
But it doesn't feel like it doesn't feel terribly dramatic to take them.
I think it can feel incredibly empowering. and very positive. In fact, when patients are asked to stop hormones for certain surgeries, the dysphoria can come back and reemerge, and so you have to be careful. People can become very depressed without access to hormones. Again, hormones in and of themselves can be life-saving. So denying somebody access to hormones is
inhumane.
Yes.
And so then, just as this, because this is, remember, this is just for the people who might never have come across this.
Yeah.
So you transition assigned males to females and assigned at birth females to males.
Yes.
There are multiple different surgeries that someone can have. And by the way, I just want to be clear that I understand that transitioning doesn't have to involve any hormones or any surgery.
Yeah,
You transition when you decide to transition. But in that transformation, that physical transformation, what kind of surgeries have you done before, let's say, when someone is to transition to trans man?
So the surgeries available to transmasculine individuals, the most commonly performed operation is a mastectomy or chest masculinization, where the breast tissue is removed. For that operation, you don't have to be on hormones for a certain period of time. Again, many individuals are, but it's not a requirement.
It's quite similar to a breast reduction.
The scars are different, and in a breast reduction, you're sort of feminizing and lifting the breast. In chest masculinization, you're removing all breast tissue.
Got it.
The scars are placed in the pectoral shadow to emphasize the contour of the pectoralis muscle, or just around the nipple if there's not a tremendous amount of breast tissue to remove. So in a breast reduction, there's still a very feminine appearance to the chest.
Got it.
And for the transmasculine patient, there are two types of genital surgery that can be performed. One is called a metoidioplasty, and the other is called a phalloplasty. And for those two surgeries, you do have to be on hormones for at least a year.
Okay.
For the transfeminine patient, so the patient who's transitioning from male to female, there are three, I would say, general categories of surgery or feminizing surgery. One would be facial feminization. And although hormones are not a requirement, they will definitely improve the aesthetic results. So it's amazing to see the changes in the face that occur from being on estrogen for just a year. That said, people will still have surgery prior to starting on hormones. And facial feminization can be life-saving and protective against violence and discrimination. Then there's breast augmentation, and we generally recommend that patients are on hormones for 6 months to a year to really see what their maximal breast growth will be in response to estrogen. It can be quite impressive, and it can soften the tissue and allow for better placement of the implant. It doesn't necessarily mean they won't need surgery, but it just will make the surgery that they eventually have a bit easier and a bit more precise. And then for vaginoplasty, which is the genital surgery available for transfeminine patients, there is a requirement for 1 year on hormones.
And is it inappropriate for me to ask what actually takes place during that? Or is that... Okay, great. Just checking.
As long as you guys are okay with...
No, I'm very comfortable. I want this,
Yeah.
I feel like it's really fucking important that we destigmatize this conversation and don't make it something that's awkward to talk about. And I think that because people are afraid of asking about it, they end up not knowing about it. And it's no different to any other surgery. In my opinion, it shouldn't be considered different to any other surgery that you need to save your life. So would you talk us through what happens, let's say, as you was just with the transfeminine, is that what you called it?
Transfeminine, yeah.
So could you talk us through the transfeminine genital surgery?
Yeah. So embryologically, genitalia are the same. So everyone starts out with the same genitalia, and then in response to hormones, so in response to testosterone, the genitalia will grow and come together at midline to form a penis, and then you'll have testicles.
And that happens before birth?
Yeah.
That's happening in the uterus.
Right. And so when we do a vaginoplasty, we basically are using all the same tissues and repurposing them and taking you back to birth or before you've been exposed to testosterone. So the tip of the glans penis becomes the clitoris. The urethra is shortened, and the testicles are removed, the erectile tissue is removed, and the extra scrotal skin is used to line the vagina. So we create a vaginal canal between the rectum and the prostate, a space that is normally closed or fused. We then create a vaginal canal, and we line the vaginal canal with penile skin and scrotal skin. And I work together with a urologist, Louisa, and we use the robot, actually, to dissect this vaginal canal, the space, and we cap, so we add additional...
You use a robot?
Yes, the robot.
What's the robot?
So the robot is used in a lot of pelvic surgery.
Okay.
It's used for hysterectomies. It's used for colon surgery that's very low in the pelvis, and the surgeon's still operating.
Just casually throw a robot around. Go on.
There's still a human behind it.
Yeah.
So the robot gives we visualization, less blood loss, and the pelvis is a tight, deep, dark space that can bleed a lot.
Right.
And so we feel it improves the safety, the visualization.
It's just a medical instrument.
It's a medical instrument.
Fine. Okay.
That's it.
Because I'm fully imagining this getting up in there, and
it
so
does have.
Oh, sure.
It does have a few arms, instruments in there.
It's limbed.
Yes.
Okay. So, how long does it take to recover from that surgery?
So,
and how painful is it?
Patients do really well. They're minimal narcotic requirement. At least our patients have very limited narcotic requirement. They're up and walking on the second day. There's packing in the vagina, and there's a catheter in the bladder. And we pull the catheter, and we pull the packing. And the hard part of the recovery, it's not painful, but it's very labor intensive. You have to dilate, so you have to put a plastic form into the vagina 4 times a day, and that maintains the width and the depth of the vagina.
To stop it from scarring over and then closing up.
Right, so your body's natural tendency is to close that space, and dilation keeps that space open. So doing anything 4 times a day is really hard. I mean, putting cream on your face 4 times a day is hard. So, and you
How
do
long
that
are you doing that for?
4 times a day for the first 6 weeks, 3 times a day for the next 6 weeks, and then twice a day until the first year is done.
Okay.
So people can generally go back to work at 6 weeks because they can figure out how to make their dilation schedule work. They're physically feeling good. And great, actually.
And what happens with nerve endings?
So
for example, if you want to have penetrational sex, can you feel that?
Yes. So you should be able to orgasm, so you can feel everything. The tip of the glans penis is the clitoris, and then the prostate, which also has nerves, is within the vaginal canal. And orgasm's so complex, and everyone orgasms in a different way. And so some people will achieve orgasm through clitoral stimulation, and again, the nerves are preserved. And others will achieve orgasm through stimulation of the nerves that are on the back of the prostate. So when the canal is actually penetrated.
And then would you need lubrication in order to be able to have sex?
Yes. So we do use something, there's a big myth out there. We use what's called the peritoneal flap. So the lining that is around the organs of your body is called the peritoneum. And we deepen the vagina with peritoneal flaps. There is a myth, I think, that this provides adequate lubrication for penetrative intercourse. But if you think about it, your belly doesn't expand in response to stimulation, erotic stimulation. And the lubrication industry was not invented just for the neovagina. There are plenty of cisgender women who use lubrication. So what we tell our patients is you may have some lubrication from the peritoneum, but it's never going to be adequate, at least in our experience, for penetrative intercourse. So everyone should still use lubrication.
Great. I was just wondering.
Yeah.
These are just questions.
No, these are
out there.
good questions because it's like a hot topic.
Oh no, I know. And also it's I just find that there's so much misinformation out there, and so I would rather we just get the facts straight from a surgeon. especially a surgeon from NYU. Langone. Okay, so then take me through, if you don't mind, transmasculine genital surgery.
Transmasculine genital surgery is definitely more complicated. There are two options. One is what we call a metoidioplasty. So in a metoidioplasty, you're using natal tissue that has grown in response to testosterone. So the clitoris or the natal phallus has elongated, and you will remove, for many people, you'll remove the uterus, you'll remove the vaginal canal, you'll create a scrotum, and you will lengthen the urethra. So you haven't added tissue, but you have reconstructed it so that it is masculine. With a phalloplasty, you are taking tissue from most commonly the arm.
Sorry, wait. So with the other surgery, there will be no phallus?
There will be a phallus, but it'll be much smaller.
Okay.
So some people will have 1 inch or 2 inches of growth in response to testosterone. Others will have just a few centimeters. So it's definitely smaller, and will be variable based on your response to hormones. With a phalloplasty, you're taking tissue from most commonly the arm or the thigh, sometimes the back, and you are creating a phallus, and you're transferring it, taking the blood vessels and the nerves and reconnecting them in the groin. And then you're lengthening the urethra, you're creating a scrotum. That's a much bigger surgery, longer recovery, and a donor site on your arm or your thigh that's very visible.
Okay.
But you get a longer phallus, and you can have an erectile device placed in the phallus, in a phalloplasty, if that's what you choose.
Oh, you can have a device?
So for some people, penetrative intercourse is one of the goals of phalloplasty.
Yeah.
And we can place an erectile device to assist with erections and facilitate penetrative intercourse. Now,
is that an internal?
It's the same device that you would place in a cisgender male with erectile dysfunction.
I don't know about this.
Yeah.
So what is the device? How does it work?
So there are two types, actually. One's like a malleable rod, like Gumby almost. And it's a rod that goes in that can bend and stiffen.
How do you control it? How do you make it work?
You bend it, and it stiffens the penis.
Okay.
So if you want the penis to be erect, you make it erect. If you want it to be flaccid, then you you point the erectile device down. The other is the pump, where there's a reservoir of fluid that's usually one of the testicles, and you literally inflate it, and it inflates one of the rods in the penis, and it provides an erection.
Amazing. And again, where are the nerve endings?
So the nerve endings are separate. The nerve endings have been connected. So let's say you take your arm. There are two nerves here that we then connect to the dorsal clitoral nerve. So the clitoral nerves are then connected and innervate the phallus or the arm.
Fascinating. Thank you so much. It's the first time I've read so many things about this, but so many people just skirt around it and don't just explain it really clearly.
I hope it was clear.
It was so clear. And so therefore I was able to finally, it just demystified it to me. And hopefully it will to other people. And how long is the recovery time for the...
So for the phalloplasty, the recovery time is, again, I would say 6 weeks. It's a big operation. You have, tissue, you're dealing with multiple sites in your body that have been operated on. So the recovery is a little slower.
Okay. But inherently worth it for those who've had it?
Yeah.
Yeah.
Again.
Well, thank you so much. I really
you.
appreciate this.
Oh my
and I
gosh.
appreciate the work that you do and the reasoning behind it. And I hope that this has been incredibly informative to anyone else watching, because I've learnt so much just in the last 10 minutes. So thank you.
Thank you for having me.